Um, Dr. Yadoli, um, good to meet you. I think people
Hello.
getting from their last Zoom, so they're onto this one. So just be a minute, but thank you for coming.
Thank you.
Hi, Azadeh. Welcome.
Thank you so much. Thank you very much for having me.
My pleasure.
And you can hear me, am I right?
We can. Are you able to screen share it? We can just, as
Yes.
people roll in, make sure that that works okay.
I will do that. Make sure that everything is going to work out well. Are you going to have any storm or freezing rain or any of the surprises that we have here?
Just the usual Midwestern early spring rain, but hopefully nothing more dramatic than that.
So you can see my screen.
Perfect. Yeah.
Okay. And hopefully the internet wouldn't surprise me, so we'll see.
Yes.
No, we did have a serious ice storm,
Oh, really?
especially not in Toronto, but like north and then east, like that a lot of power outage and everything. And today is going to be freezing rain, so either people didn't show up to the office.
Oh, goodness.
And leave early.
I think we're all ready for warmer weather.
I know, it just, and every day I wear some, not today, like wear something green. I'm like, I feel that if I wear green, this spring will come.
Yes, you manifest it. I like it.
I have to try that.
That's my share. Wearing green, maybe something.
I like it. It's worth a try.
I know.
Yes. Well, we will go ahead and get started. So hello, everyone. Welcome to our Grand Rounds today. It's my pleasure to welcome Dr. Azadeh Yadolahi, who holds a Canada Research Chair Tier 2 in Cardiorespiratory Engineering, is a senior scientist at the University Health Network's Kite Research Institute, an associate professor at the University of Toronto's Institute of Biomedical Engineering, and an adjunct faculty member at the University of Manitoba. Dr. Yadolahi is director of the Fabric-Based Research, or FIBRE platform, with the vision to deliver revolutionary textile-based wearables for providing equitable access to healthcare wherever users are. She's also the 2025 IEEE Engineering in Medicine and Biology's Distinguished Lecturer. So we are thrilled to have you here today and excited to learn from you about digital technologies in the assessment of sleep apnea. So thank you for joining us, and I'll turn it over to you.
Thank you very much for having me, and I'm quite honored to be here today. And I was nervous when I was thinking about what I'm going to put into this presentation, because I did some changes in terms of what I usually present. As Anita mentioned, this topic of my talk is about the development of novel digital technologies for assessment of sleep apnea. I don't have conflict of interest. And there were 3 topics or objectives that I thought maybe I can discuss, or I hope that I can share with you in this talk. The first one is to sort of review the application of acoustics and speech processing to assess cardiorespiratory signals during sleep and sleep apnea. The second topic would be discuss the application of smart garments to assess cardiorespiratory signals. And the last one, which I hope that I get time to discuss, is the importance of co-design and co-development of these technologies with the end users. So in terms of the first objective, we all know that sleep apnea is a common problem. It happens when the airways are collapsing during the sleep, and then some symptoms like sleepiness or snoring are common. And the big challenge is that because the current methods or gold standards for assessment rely on in-lab or portable polysomnography, it is highly underdiagnosed. So me being an engineer and then being so passionate when I started my PhD in 2005, I thought that this is one of the easiest problems to solve, and that should be quite easy. So what if we can use a microphone and then we attach the microphone on the trachea, we're recording tracheal sound, and then the airway is like a music pipe. So what we did was we put a microphone here, this old Sony microphone, and then we had the people breathing through their mouth while they were awake. And we showed that because there is an association between the energy of the sound and the amount of the airflow. If, for example, this is the sound that is recorded over time, and then this is the airflow recorded with the pneumatag, and people are starting from like shallow breathing and then higher amplitude of breathing all the way to very like deep breathing. If you look at the energy of sound, look at some signal processing, we can estimate airflow. I mean, this is one of the best data that we got, but then we can see that how nicely we can look at the sound energy and then have an estimate of the airflow. And then so surprised about the results to said, let's solve the problem of sleep apnea and then make the revolution. So again, this is me having our technology, like microphone with the wire, and I did my first sewing for a while to make a band to sort that we can hold it in place when people are sleeping, made the box that records the sound, amplify the sounds, records the oxygen level in the blood, and then get the 2 of them, analyze the data for overnight, and then we did it in people with at the same time with the gold standard in-lab polysomnography. And we showed that if you look at the sound energy, look at the pulse oximetry data from the finger probe, and develop these algorithms to look at like basically rises and drops in the sound energy, we can estimate AHI or apnea-hypopnea index. And what this graph is showing is in about 50 people, the horizontal axis is gold standard apnea-hypopnea index, and then the vertical is what was predicted based on the sound and oxygen saturation, and the results were quite impressive. And then it moved. I mean, I moved in my career. I became sort of doing a postdoc in Toronto, and then that technology and that box got smaller and smaller. We improved our design so that now we could have something small that includes everything in a small patch over the neck that we can record like both the sound with a microphone. It has an accelerometer to look at the movement of the trachea, and then basically do a lot of the analysis offline. And then we license the technology to a company to commercialize that. So this is sort of the history of some of the work that I wanted to show today, that how with that basic knowledge of the physiology and then the generation of the sound, and assuming that the airway acts as a pipe, like an instrument, and there's an association between airflow and sound energy, we're going to look into different ways of improving the assessment of a sleep apnea. So we improved our model, and then what here are some data that I'm going to show from the recorded during sleep. So we used a similar technology. As I said, it has a microphone, it has a three-dimensional accelerometer, all built in this small patch. And this is an example of data collected during sleep at the same time with full polysomnography. And then so this graph shows the nasal airflow with the tubes in the nose, and then the positive is inspiration, the negative is expiration. Here is the sound energy that, as you can see, is always positive. And then we developed algorithms to basically collect the sound energy, clean up the signal, and then have detect inspiration and expiration and estimate airflow. And as you can see, there's a nice sort of up and down in the sound energy, in association with the nasal pressure. We showed that even when the people are snoring, and then here all these high frequency components in the airflow are showing a snoring, we are still able to look at the sound energy, remove the impact of the snoring from the breathing sound, and then estimate the airflow. And then we do have some sort of also these plateaus showing that the flow limitation in the because of the narrowing of the airway. Similarly, this example shows when the people are having hypopnea. So here there is a drop in the level of the airflow. And then from the sound, we also have relative drops in the estimated airflow from the sound. And then when there is a apnea or full drop in the oxygen in the airflow from the sound, we also see some drops in the estimated airflow. We have some movements or some levels of energy here when there is no airflow from the nasal pressure. That could either be the noise in our recording or because that the nasal pressure has some leaking that cannot detect this level of activity. We then use
The question.
Yes.
Sorry, is it just a quick question? Is the only thing that the device is recording is sound energy? Is that correct? Or
It's just a sound like a microphone. It does have an accelerometer too. That will go to some of those that basically looks at the movement, but these are the only two signals. And the whole idea is that the energy of the sound is related. I mean, if there is a normal breathing without any noises, the energy of the sound is related to the amount of the airflow. And then when there is a snoring, if you remove the impact of a snoring, then we can then have an estimate of the airflow based on the sound energy.
So the first graph there is from the polysomnogram, the second is from the device, and the third is calculated by the device.
Exactly. So the two are from the device, from the microphone, and the first one is from the polysomnography. So we just used a similar method that we have the respiratory sound, and then we estimate the energy and estimate the amount of the airflow to see how good we can detect a sleep apnea. So again, this is data in about 67 or about 70 participants who come to the sleep lab. And at the same time, we did the full polysomnography and the recorded data with the device. And this is an example of the data that we have. Do you see my cursor? You should see that. Yeah. So
Yes, we
here's
can.
an example of an apnea, that there is a drop in the airflow, or in this case, like the chest and abdominal movement. This is the sound energy, the sound data that here are inspiration, expiration. And then when there is an event, there is no data in the sound. And then by looking at the SpO2 signal to find the drops, and then also looking at the sound energy, we estimated the apnea-hypopnea index. And this graph shows here the horizontal axis is the apnea-hypopnea index from the polysomnography, and the vertical axis is from the device with a very good correlation. The novelty of this study compared to the previous studies that we have done was that we also look at individual event, because you may get a good AHI, but miss a lot of event or basically have false positive. And what we found was that our precision and recall was around 0.6. especially or higher at higher AHI. So we can detect individual events too. We try to see if we can make the algorithm simpler. And the reason is that when we are collecting the movement of the trachea over movement over the trachea, one good thing that we have is not only we have the sound of breathing, but we also have the movement of the skin due to inspiration and expiration. Very, similar to what we make it over the chest movement of going up and down. And what we did was just look at the movement. So just look at the accelerometer data. And then what we found was that especially in the direction of the Z coming up and down, if you just look at that, we can still estimate the apnea-hypopnea index with a very high correlation. I mean, it's 0.84 because we're not looking at the pulse oximetry, just looking at the movement over trachea, but still the results are promising. And then the beauty is that the signal is much less complex compared to the sound than oxygen saturation. The other thing that we have done, and quite sort of one of the reasons that we really like collecting data over the trachea, is that when we are collecting the sound over trachea, we're also recording heart sound because we're very close to the jugular vein and then also the carotid. So we get the heart sounds with a very good quality, depending on the size of the neck, obviously. And we were interested to know that how good we can look at the extract heart sounds from the recording and then see if we can use that to look at the changes in the heart sounds, especially during events. The big challenge of doing that is that when the people are snoring, the intensity of the snoring is very high and it's hard to look at the heart sound. So this is an example of the data that we collected. So the top graph is ECG from the polysomnography just as a reference. And then the second graph is tracheal sound collected with our microphone or our device or patch. And this is an example when there is snoring. So this high amplitude red signal is the snoring, and then this is like the breathing. So the first step was really, so this is like, it starts with inspiration, then we have a snoring during inspiration and then expiration after that. So this shallow or like lower amplitude is expiration, and then the same continues. So what we did was from these collected sound, remove the snoring sound, and then so that we can get a combination of tracheal sound and then also heart sound, and then filter the signal to get the heart sound. So these ones are extracted from the sound and then from this data after removing the snoring, and this is the first and the second heart sound during sleep. And what we did to know that whether this data or these results are reliable, in the same population, we looked at how good from the heart sounds you can estimate heart rate and then compare it with the ECG-based heart rate, and we showed that the results are quite accurate. That I haven't shown here, but what we were also very interested was that whether the intensity of the heart sound may change when there are respiratory events, and that could be associated with the severity of the event, or whether that the cardiac function or outcome may increase depending on how sort of deep or how severe the apneas or hypopneas are. And we know that the recent studies show that the changes in heart rate from pre to post event are also associated with cardiovascular outcome. So what we did was during the apneas and hypopneas, we looked at so if this gray graph or gray bar shows when there is an apnea or there is an event, and the pink is the arousal post-event. What we did was we looked at the 10 seconds of the data before an event starts, and then 10 seconds after arousal, and then also 10 seconds before termination, just before arousal, and look at the heart sound intensity in these periods to see how they're changing. So again, this is ECG from the polysomnography. This is the airflow from polysomnography, and then oxygen saturation that we use as the reference, and then also to find arousals. And then the other 4 graphs are what we collected from our data. So tracheal sound or recorded and then estimated heart sound intensities. And this is an example of the data that we found. And what we showed was that when we look at the heart sound intensity for S1 and S2, before starting the event, before termination of the event, and then after the arousal, for both sound intensity, there is a significant increase in the sound intensity after termination from before termination. And this was also associated with a significant increase in heart rate. And this was higher, like this magnitude of the change in the sound intensity and heart rate after termination of event was larger in those with more drops in oxygen saturation or higher hypoxemia. That could be sort of a way to look into the potential cardiac or impaired cardiac function in association with a sleep apnea. We also looked into how good we can use the sound and then the movement that we have from over the trachea to have an estimate of the tidal volume, as can be recorded with like movement of the chest and abdomen. So basically, is there an association between the movement over the chest and abdomen and the movement over trachea? And we can use that as a surrogate of the chest and abdominal movement. So here the top graph shows the sum of the chest and abdominal movement from the PSG, and then this is again the airflow from the polysomnography, and this is the energy of the sound, and then the movement in the 2 directions. So this would be Z and then the X perpendicular to that. And this is the data estimated on a breath by breath for tidal volume of the gold standard, which is the solid line, and the dashed line is what we estimated from the sound, from the movement of the trachea. And the 2 of them sort of following each other in terms of the magnitude of the breathing throughout different breaths, suggesting that there's a high association between movement of trachea and movement of the chest and abdomen. Sorry. Because we're quite interested in how good we can assess respiratory function during the sleep from the sound, we were interested to know, and we know that the physiology is different during inspiration and expiration, but when we look at the sound energy, it's positive for both inspiration and expiration. We were interested if we can detect inspiration and expiration from the sound energy. And then it's easy when the people, or easier when the people are awake, because you can ask them to breathe sort of normally, and then you have inspiration, expiration. But during a sleep, because we have a lot of movement, there could be apneas and hypopneas, and then we don't have that frequency or as sort of one coming after each other. So finding the proper phase is quite challenging. And so what we did was basically to see if we can extract features from the shape of the inspiration and expiration to be able to estimate respiratory phase. This is an inspiration in a good. So this is a sound energy during inspiration that is sort of resemble a bell shape, while during expiration, it is sort of skewed to one end. And so that's the basics of what we did. We tried to find features in different parts of the signal and use that to detect the respiratory phases. And here are the examples of the data, again, during different types of breathing, during a sleep. And similarly, again, the top flow is airflow from the polysomnography. The second one is the sound from the microphone. And then the third one is the movement from the device. And then the last one is the sound energy. And then we try to basically mark inspiration and expiration with red and blue. And there are examples during apnea, during snoring, during hypopnea, and during normal breathing. And what we found was that overall, again, all the data is in the same population of about 70 people. When we look at the percentage of the breaths that we missed, in average, we our error is around 9% during normal breathing or snoring, and it becomes higher when there is an respiratory event. And we also looked at what is the delay between the respiratory phase detected from our method based on the sound and the gold standard based on airflow. And then the error is in the order of 180 or 190 milliseconds. So that's how much delay we have to find respiration. So all of these together show
Can I
that,
ask a question?
yes,
Is the airflow nasal pressure?
yes, in this one is,
And
yes,
is that precisely accurate time-wise? Because I know that thermocouples are delayed a quarter second. How about the
it
nasal
is,
pressure?
it is not. I mean, it's like, your point is quite valid that finding an accurate beginning of the inspiration and expiration from the nasal pressure by itself is quite challenging because you are also having a drift in the signal over the time. So it's not as simple looking at the zero. So we have to develop algorithm that we can basically follow those changes and find the beginning and end of inspiration. And then in some cases, try to look at both the airflow from the nasal pressure and then also the movement of the chest and abdomen to see if we can make that more accurate and to use that as the gold standard, which I skipped in this for simplicity here. But that's a very valid point that gold standard by itself could have error too. So then, knowing that we really wanted to look into the different signals that we're getting and then how we can improve the sounds or the assessment to get more accurate assessment of the respiratory function or the assessment of the sleep apnea. We also go more in depth into the snoring sound. And the reason that we looked a lot into the snoring was that how can we use the snoring to get a better estimate of the airway, assuming that the airway is basically, we try to use some sort of development of the speech, that in the speech, what we have is the vocal cord, they're vibrating, the shape of the airway is changing, and then we have different vowels or different sounds. How about if we say that in the snoring, we do have a source of vibration? It could be the tissue, it could be the air that is vibrating, and then those vibrations are basically going through the vocal tract, depends on the shape, and then we are hearing the snoring. And can we use sort of inverse engineering by knowing the outcome of the system and try to predict what the input was, like, for example, what the shape of the airway or the vocal tract was? So the goal was to do an inverse modeling and then look at the frequency components of the snoring and see if we can use that to associate with like the length of the airway or the diameter of the airway or even the tissue composition. So these were like more on the proof of concept. In one study, what we did was we looked at the snoring intensity over the course of the night, and then we also look at the airway narrowing or the size of the pharyngeal airway with acoustic pharyngometry in the evening before people go to bed and in the morning when they wake up. So what this graph is showing is the amount or the percentage of narrowing in the airway from evening to the morning, suggesting that they are having more. So basically the airway gets more narrow during the sleep. So the people who had more narrowing in their airways from evening to the morning had higher intensity of the snoring. So they were snoring louder, which makes sense. If you have a narrower tube, then the sound intensity will increase. We also, with the same use of the acoustic pharyngometry, we could get an estimate of the length of the airway. And we know that if we have a pipe and then it's we're basically blowing in the pipe, the resonance in the pipe is inversely related to the length of the pipe. So if it is longer, then the resonance frequencies are lower and vice versa. And this is very much what we found, that when we look at the resonance frequency or F1 of the snoring sound, and then also the length of the pharyngeal airway in this population in the oropharynx, those with the longer airway had lower resonance frequencies. And then finally, the other thing that we did was that what happens if the tissue itself is changing? So again, we did a very simple model as a proof of concept that if we monitor the amount of edema in the pharyngeal tissue, so we looked at bioimpedance, we looked at the amount of the estimate of the fluid in the air, in the pharyngeal air, or like the neck tissue around the airways in the evening and in the morning. And the hypothesis is that if the people are getting more fluid or have more fluid in their neck, it's like the tissue is going to do more dampening of the sound because of now we have more edema. And what we found was that the people that had more fluid accumulated in their neck throughout the night had more changes in or had lower frequencies or central frequencies associated with the snoring, suggesting that the resonance frequencies are also changing with the amount of edema. So all of these studies were sort of a proof of concept that if we look at the intensities of the snoring or frequency component of the snoring, it could be a surrogate or to resemble the changes in the shape of the airway. So we tried to do a bit more. Sorry. So we try to see that can we extend this study and then to go to the basically how the speech is produced, and then if we can use that data to have a better understanding of the shape of the airway. And the reason that again we're coming to this is that when we're talking about the speech production and the snoring or the shape of the airway itself and the tongue are really working together, have very similar functions during a speech production and then also during a sleep, because tongue is the main muscle that is changing the shape of the airway during a speech production. So this is like some of the very old literature in the speech or vowel articulation. And what is showing is, assume that this trapezoid is tongue or the oral cavity and where the tongue is. And then what this one is showing is that if, for example, when we're saying the vowel E, the tongue is coming forward and up. So the airway or the pharyngeal airway is the most open. If we say U, then the tongue is going back and up, or like to the top of the mouth and then going all the way to the back. So the airway or the pharynges become narrow. And then if we say ah, like cat, what happens is that the tongue is going down and back. So then the airway is sort of as its narrowest. And so these, and then this is well used in the speech and vowel articulation, and then how to try to use that to find the resonance frequencies that are like these peaks in the signal and use that for detecting the speech or even detecting the speaker. And we thought that to use a similar thing to see if we can use a speech to look at the shape of the airway or the risk of a sleep apnea and airway narrowing. So what we did to, first of all, to know even if it's working was in order to find the shape of the airway during the vowel articulation, one way is to do MRI, which is so expensive and it's not feasible. What we did was to develop a protocol based on ultrasound. So we basically have the probes of the ultrasound in 2 dimensions, like the transverse and then the parasagittal. And we asked the people to say different vowels. And then they used to say 5 different vowels like E, E, U, O, and A. And we look at the size of the airway in these 2 dimensions for different vowels. And this is an example of what we get. And we assume that if we get the length in the 2 dimensions, we get this estimate of the size of the area of the pharyngeal airway. And so in one, at the first step, what we have done was we basically looked at the cross-sectional area of the pharyngeal airway with acoustic pharyngometry. And then we also look at the parasagittal parasagittal anterior posterior diameter based on the ultrasound. And we showed that, yes, there is a good correlation in about 30 individual with and without the risk of a sleep apnea between the two diameters. So what we are estimating from the ultrasound is correlated with the shape of the airway or cross-sectional area of the airway, and this is during normal breathing. Then we looked at the same diameter, parasagittal anterior posterior diameter, during different vowel articulation. And here the blue is showing the people with low risk of a sleep apnea, and the red is showing data from those with high risk of a sleep apnea. And here we assess the risk of a sleep apnea based on questionnaire. And what we found was that in two vowels, like E and A, there was a significant difference between the two groups of participants in terms of the size of the airway. And as expected, the diameter was higher in those that have low risk of a sleep apnea, lower BMI, and lower neck circumference. What was quite interesting for us was that when we looked at the people with low risk of a sleep apnea, based on the questionnaire, and high risk of a sleep apnea, and then we looked at the size of or the length or the diameter of the parasagittal anterior posterior diameter, not only that during E, the diameter was larger in those with low risk of a sleep apnea compared with high risk of a sleep apnea, but when we look at the change in diameter from E to A, so like when it is the most open to when it is the most closed, so these change in the diameter was larger in those with low risk of a sleep apnea compared to the high risk. And this is also seen with the other studies that have done with the MRI to look at the change of the tongue movement and then the range of changes in the airway size in people with and without a sleep apnea. And what it shows is either because the tongue is bigger in people with higher risk of a sleep apnea because of more fat in the tongue and then the size of the tongue itself, so there is less movement, or it's just that the tongue is more stiff in people with higher risk of a sleep apnea. We also showed that if you just look at the frequency components of the sound, they're different for the vowels in people with low and high risk of a sleep apnea. And we can develop models to predict the length of the airway from the sound features. And then we got more excited about what else can we do? What is in the literature about using a speech for sleep apnea screening? So we did a literature review and a systematic review of the literature, and we come up with about 32 studies that in general looked for detecting a sleep apnea, either the risk of a sleep apnea or the severity of a sleep apnea based on a speech. And what we found was that among these studies, some of them are using vowels, some of them are using vowels and phonemes, some of them are using sentences, and in some studies, they're just trying to find what are the main features that are contributing to sleep apnea severity. In some studies, they're using different models to classify people into with and without a sleep apnea, and the accuracy is around 79%. And in some studies, they try to do regressions and then estimate the apnea-hypopnea index. And in general, the correlation between the estimated AHI from the sound and the gold standard AHI is about 0.6. But what the main challenge of a lot of these studies was that the data was very biased, that is either focused only one ethnic, one race or a very specific population. So there was no diversity in the population in terms of the sex, in terms of the age, in terms of different race, that all of the factors that could change both sleep apnea severity and then the airway physiology. The method to assess sleep apnea was quite different among the different studies, and then also how they developed the models to estimate AHI or the thresholds was different. And a lot of these studies also focus on only one side, so one very sort of specific or limited sample size. So what we tried to do was to see if we can have a multi-site study and then collect data, or our goal is to collect data from about 2,000 participants that are diverse in terms of the age, sex, race, and then also the health condition that could affect the airway physiology, and see if we can use that data of the sound or speech and a sleep study to develop models to detect the risk of sleep apnea. And this is the study that we are very fortunate to have Dr. Devin Brown to also help and collaborate significantly in collecting data from Michigan. So the protocol that we have, it's a bit different across the different sites, but basically the idea is that the people are going to the sleep lab for sleep studies, either research sleep study or clinical sleep study with a polysomnography device. And then before going to the sleep, we ask them to say different vowels in front of a camera, like a cell phone or an audio recorder, and then in different position, like in the front and then from the profile posture. And then in the first step, we look at basically the sound features. And then here what it shows is each graph shows the data from one vowel, like E. And then we look at basically the sound energy in different frequencies. So the horizontal axis shows the different frequency components from 0 Hertz to 10 kilohertz. And then the vertical axis shows the energy of the sound. The red is data from the people without sleep apnea. And here the threshold was 10 events to classify participants, and the blue is participants with sleep apnea. And when we look at the data, just basically, if the features are different, we found that for some vowels, especially in both seated and standing postures, for A, and O, the sound features are different between the two groups, especially in the higher frequency components. And that's how we use the acoustic features or features from the sound and the vowels to look into whether we can use that data, develop models based on machine learning, and then do two tasks. One task is to classify participants into with and without sleep apnea, and the second task is to estimate AHI. So the input is the recorded speech when the people are awake from these different vowels, and then the gold standard is the AHI based on the polysomnography. We pre-process the data to remove the noises. Then we give the data to different models for extracting features from the sound. Some are deep learning models. Some are looking basically just the acoustic features like the sound energy. And then we develop different models from them, get the output from each model. And then based on the output of these different models, we put them all into a fusion model to estimate the AHI and then the risk of sleep apnea. And here is the data that we collected at the moment from 150 participants across 3 sites. And then of these 150 participants that are quite, we have a wide range of age, BMI, and sleep apnea severity. And in terms of race, we have white, black, Asian, and other. And about 108 people have a sleep apnea, and then 43 don't have a sleep apnea. Again, here is with different thresholds that we have. We looked at 2 thresholds of 10 and 30. And what we found was that for both thresholds of 10 events per hour to detect a sleep apnea or 30, the model that we developed has an accuracy of about 84% to detect individuals with a sleep apnea for both male and female. And then when it comes with the higher AHI, the accuracy is dropped, especially for female. But if we look at, actually, so it's about 0.8 for both men and women. If we just look at the demographics like BMI, Epworth sleepiness, age, the accuracies for detecting a sleep apnea is much less compared to 0.5 to 0.7, suggesting that if we say that the equivalent of the a speech in terms of the complexity is similar to questionnaire, that both are trying to detect the sleep apnea while someone is awake. The speech is giving a much higher accuracy in terms of detecting, classifying people in with and without the sleep apnea. And the importance here is that we can do this while people are awake, so without the need to do it during sleep. We also looked into how good we can estimate AHI from the sound features extracted from different vowels. And again, these are different models or different classifiers that we have. And what these two columns are showing, this one is the mean absolute error between the estimated AHI and the AHI from the polysomnography, and R is the correlation between the AHI estimated from the sound relative to the gold standard. And this graph shows basically the data, individual data of these 150 individuals. So the horizontal axis is the AHI from the polysomnography, and the vertical axis is estimated AHI from the sound. And as we can see, in both male and females, the correlation is about 0.6, and the error in terms of the events is 12. It's not impressive, but what is quite important here is that, first of all, it's better than the questionnaire, but the data is much more robust when it comes compared to the other previous studies, because now you're having data that is not only in one population, but from different sites, and then more diverse in terms of the race, and then sex and gender, sex and age. So, and then these are the people that really made these part of the speech-based assessment happening with all the contribution across different places. I'm going to go to a different topic, but is there questions so far, or are we going to have questions later?
I have a quick question.
Yes.
Just because I've seen this in the literature and I have more surface understanding of machine learning, not like you as an expert, but that last step in developing the classifier with the fusion model, how does that work? Is that a regression? Is it something that kind of reduces what you get from the deep neural networks? Is it different in different cases? I just wanted to, because I've read about it in methods sections and I've never understood it.
So what happens is that in the very simple case, it could be like a weighted average from the different classifiers. So basically you have different classifiers because each one of them is one classifier that is coming in different models. And then you're having that. And in the easy or the simplest way, it could be a weighted average. And what happens is that those weights are going to be adjusted based on like the results of different models to make sure that we get a better, like a higher accuracy. And how those weights are adjusted is when we collect the data, we put part of the data for training so that we can find like, actually we make it into 3 different parts. We have a part of the data, say 60% for training to find all of these models. And then we use that in another 20% as like a validation, just to make sure that how the models are good, and then do we need how generalizable the model is. And then we use another 20% of the data that we haven't seen and we haven't touched for any of these development for testing, and that's where the results are coming. But those fusion is similar to what you mentioned. It's sort of a regression, but those weights of the regression are coming through these different trainings. And that's why this AHI is coming here as basically adjusting these models, the parameters of the models, and then also these weights from the different classifiers.
And then, Ron, did you have a question?
Yeah, when are we gonna go to the App Store and get your app and then just put it by our bedside to record noises we're making at night, and then tell us whether we need to get, further attention for it?
That's a great point, that we could do that. and then go and then get a mobile app to get the snoring and then do that. It's just that for all of those, you need to have data overnight. And the
Okay,
beauty,
I'll keep my phone right by my pillow.
yeah, you can do that. But like if you go to your physician, like to your family physician, and we're talking like this, your family physician cannot tell you if you have a sleep apnea or not on the site, and then have to send you home and get that data. But if you have the data and you can do that while the people are awake, it just makes it much simpler. So you don't need, you remove that need of sleeping.
Let's see, so you think that they could go to their clinician and then say, here, read this page while you hold your phone in front of your face, and that'll be enough, and it'll be that fast?
Yes, but that's what we hope. And it
Oh.
won't be reading the whole page. It would be like saying different vowels or maybe a few sentences. That's the dream.
Okay, that's good, but don't forget, you know, we have to send them information before they come to their appointment anyway. We could tell them, go do that app before we see you overnight. That's another option too.
Yep, absolutely. You can, and that's why there are a lot of studies going and doing that to do like looking into the apps. And then the question would be that how accurate those are, and then looking into the accuracy. But when we're talking in terms of the speech-based model, is how good you can do that relative to questionnaire.
Yeah, I understand. But you think the speech-based model will be more accurate than the other data you showed about the sounds? The tracheal sounds, or I assume eventually it could be just not even on the trachea, it could be touchless.
So I think that tracheal sound would be more accurate than a speech, but then you do need to, like for those ones, you're collecting it during the sleep, and then you need to touch, which may not be comfortable. So the beauty of the speech is that you don't need to connect anything, and then you can record it much more easier with any device that you have. While the problem that we have with that recording tracheal sound is that you still need the hardware and send something, and that's what they need to do, send something to the people to record it. So the idea was to remove that need. There are other things that are good about the speech, and again, these are more speculation, but basically, and you still can maybe get those ones from snoring, but when we're getting from the speech, we can also see that or develop the models that may be able to separate narrowing in different levels of the airway. For example, I'm sure that you all know what happens or when you have someone in the clinic and they have narrowing in the nasal cavity, and you can, I mean, like just listen to that and know what's happening. And then they have probably some sort of deviation in the nose. So the narrowing is coming from the nose compared to the air, like the pharynx. So those are the other things that comes from the speech or from the sound features that can be improving the features of the sound.
Thank you. Neeraj, did you have a question as well?
Oh, I'm good. I think I had a similar question to what Ron asked.
Okay.
So I think one comment and a question, I guess, at the same time is these probabilities and mathematical modeling leads to a risk assessment, not a diagnosis assessment. Meaning you are risk for having sleep apnea potentially at your speech pattern or your vowel patterns. Is that something that would at some point will say, oh, you have a diagnosis because you say the vowel this way versus that way?
And that would be, and that's why I mean, that could happen if we can develop the models in like a large database and then having a data. So to be able to say that, yes, we can diagnose, is that to be able to test it, like have data in a large group and say that we are developing the models in a group and then test it in another population. So technically, we think that, yes, you could get to the point to do the diagnosis, but without that validation, and that's why this is an ongoing study, we can't say that, at least yet.
Is it a standardization of when you ask that vowel, like what time of the day pattern of the vowel speech pattern changes on a time of the, when I'm at the end of the day, my speech may be different than in the morning, I guess. I'm just trying to understand that.
That's a great point. In terms of what happens, like what happens if you're tired, because all of those could change. And that's the other beauty of the speech, that can maybe get other like sort of functions of the overall health. In this one, we're only focusing on the vowels, at least to remove those elements of if someone is tired or if they have different accent would be less. And that's why we focused on the vowels. But in theory, yes, the time would be affecting the quality of the sound potentially. And for example, because if there is more fluid, like just circadian changes and then more edema, even subtle edema in the vocal cord, you expect that the sound features will change. And that's why some studies looked at the vocal cord or the sound features as to estimate pulmonary edema.
Thank you.
I have a related question. Does the primary language of the patient matter in terms of, what part of their palate or tongue is used more often in sound generation? Could that influence these findings?
I believe it does, especially if you ask them to say a sentence. For the vowels, we don't know. In this population that we have people that English was their first language and some that English was not their first language. And then people with and that's why we try to have that like different race in our population, like Chinese, and we went basically to different places to see how that is affecting the results. At the moment, we don't have enough data to look into that.
Thanks.
Other questions? Or shall I continue?
Yeah, go ahead. Thanks.
Sure. So the second sort of application that I'm going to touch or talk a bit is how we can have smart garments to assess the cardiorespiratory signals. And the idea would be that, okay, I showed this one because I really like that. This is something that I started a while ago, and that was and I started a lot of the work that we're doing when it comes to the pathophysiology of sleep apnea, especially in people with different chronic condition. And the idea was based on the shift of the fluid in different body segments during the day and at night. And the idea is because of the gravity during the day, we spend a lot of time sitting, so fluid accumulates more in the legs. And then at night when lying down to sleep, fluid moves out of the legs to the upper body. And then if it gets to the neck and then around the pharyngeal tissue, narrows the airways in the neck or the pharyngeal airway and increase the risk of a sleep apnea, and fluid accumulation around the walls of the airway in the lungs may increase the risk of a small airway narrowing. So that was sort of the hypothesis. And then what we have done was I developed a system that measures the impedance of a segment, for example, leg or lung. And because the fluid in the body is a good conductance of the electricity because of all the ions, if there is more fluid in that segment, the resistance is reduced. If the fluid is reduced, then the resistance increasing. And then, so that was the basic idea of looking at the shift of the fluid in different body segments and looking at that to estimate how this shift or change in hemodynamics contribute to sleep apnea severity in different population. And we found quite strong results. But one problem that we had all the time was that you can't send people with all these electrodes connected to them home and then see what is the long-term impact of the changes in hemodynamics on a sleep problem, or if someone who has heart failure, do they develop more edema? How can we have more accessible methods? And what we tried to develop was, can we move from gel-based electrode to dry electrode. So instead of having like, and then you can think of it for any of the signals that you're recording. Like for example, for ECG, for EMG, instead of having gel and everything, can we have dry electrodes that don't need the gel and we can still collect data with high accuracy? And the reason that those dry electrodes are important is that because then you can embed them into the garment. So the idea would be that think of like in this case for monitoring the impedance of the segment like a leg, that you basically use some conductive yarn, like silver yarn, and then develop and knit that into the textile so that your part of your garment becomes a conductive material, and then you can collect ECG or bioimpedance, or if it's stretchable, you can monitor the respiration. And that's what we did. We tried to develop different prototypes of the sensors that are basically made of conductive yarns embedded into the garment, and then look at how good we can monitor different physiological signals. We have done that in one protocol to look at the monitoring of the impedance of the leg for monitoring fluid. We looked into another study in children that we use like a band with embedded textile-based electrode to monitor ECG, both while they were sitting, lying down, sitting, and then walking on the treadmill. And what we found was that in the children with heart disease and the healthy children, if the black is the reference ECG with gold standard, and then red, blue, and green are different channels from the textile-based electrodes or sensors, there is a high, basically there is no difference between the data collected from or heart rate collected from the dry textile-based electrode and those collected gold standard ones. So the average error is less than 2 bits, or like between 2 to 5 bits per minute in the sitting and standing, and around 12, the average error is around 3 bits per minute during exercise. We also looked into how good, because those bands are quite tight, can we make it in a way that is not very tight and still can collect or measure the ECG? So this is another development that we have a t-shirt. The t-shirt is not very tight compared to that, and then still the electrodes are dry electrodes embedded into the textile. And this is an example of the ECG collected with the gel and the ECG collected with the textile over the chest. And when we compare the heart rate from the textile-based electrode and then the gel-based electrode, there is a high correlation. This is a small sample of about 10 people that we're developing, but showing that even if the electrodes are positioned in the right place, we could collect a good data in terms of the heart rate, and then even the changes in the heart rate with the textile-based electrode compared to the gel-based electrode. We did something similar for EMG, or collecting EMG, and then these are some examples of the shapes of the electrodes that are basically embroidery in the textile. So again, these are conductive material, and this is an example of the EMG collected from the muscles on the arm, and showing that with the textile-based electrodes, we can collect EMG with a high quality. The question is, how much time do we have?
Yeah, we go until 2 p.m., so I think we need to wrap up if that's okay.
Oh, absolutely. I just wanted, yeah, that's why I wanted to stop and then.
Yeah, thank you. Yeah, I don't see any other additional questions in the chat. Lots of kudos about what a great talk this was. But thank you so much for joining us today.
Thank you so much for having me, and sorry if I was slow.
No, you were great. I think lots of interesting questions along the way, so it generated a lot of discussion. So
Thank you very
thank you
much.
so much.
Thanks. Have a great day.
Thanks, you too. Bye.
Bye.